Okay, so, yes?
Yes.
Good, okay. So what I'm going to do is, for about the first hour, we're going to talk about the well newborn. But what I have are slides and pictures of things that you might not see every day. How many of you have already been to Mother Baby and seen kids and procedures and stuff? Okay, good. So you've seen which end of the baby is diapered. So I would like you to be familiar, now that you know what well babies look like, be a little bit more aware and a little bit more familiar of what the abnormals are. Skin things and low ears and stuff like that. And then after that, I'll give you a little break and we will go on to the high-risk newborn. Those are kids that come to NICU, and I know many of you won't get to work in NICU or come shadow anybody because it's a small unit, and you kind of learn by what the other person saw. So I'm hoping to bring a lot of that to you. So what we're going to do is go on, and a lot of this is from your book. Now when you're doing a physical assessment of a baby, these are ranges of weights and measures. Lots of things can affect what the baby weighs at, the baby measures at. What do you think some of those things are? Preterm, a smaller baby is going to weigh less. Oh, it's not moving?
No. I was turning on the other side.
Oh, okay. So then, but things like culture, ethnicity, disease process in the mom, if she has diabetes, are you going to expect a smaller baby or a larger baby? So you're going to want to see a larger baby. So these are just ranges for what is a normal baby, somebody that hasn't been exposed to anything, has delivered at full term. You'll notice that the head is larger than the chest. Any ideas as to why? Good guesses I'll take? Nope. As it's coming down the vaginal canal, the head is what's coming first. So the head has to stretch out the vagina, and then the shoulders just follow it. If it was the other way around, like if you had a microcephalic baby, the shoulders would get hung up because the vagina hasn't been stretched out. So it's very important for the head to be a little bit larger than the chest and for the shoulders. When you're doing your assessment, we do the 5 vital signs just like you do in the adult world. Temperatures are 97 to 99.5. I feel 97 is a little bit cold. I prefer closer to 98. And we're going to talk a little bit about how to keep babies warm shortly. Heart rates depend on the size of the baby. The smaller the baby, the smaller the heart. So it has to pump faster, beat faster to get all the blood around. That's why a preemie or SGA baby may have a resting heart rate of 140, 150, but a big term kid may have a resting heart rate of 80 because their heart's larger. It doesn't have to pump as much. Kids that are active and screaming on a smaller baby, you might have heart rates over 200. And, bigger kids may go to 120, and that would be fast for them. Respirations depends on what's going on with the baby. After 60, we start getting concerned. We consider that tachypnea. We don't bottle feed anybody that has a respiration rate over 60. And if it's a chronic 60 and we're comfortable with the baby eating with the bottle, there's different positions that we use and different nipples that we use that make the formula come out slower. He can't suck as hard. He's not going to work any harder than he needs to. This is an average blood pressure. We take the blood pressure in the first round of vital signs, and then after 72 hours before discharge, they get what's called a CCHD, a congenital heart disease test. And it's just comparing the blood pressure in your right arm to a left leg. They can only be a 3% difference. And then if it's more than that, we start thinking there might be some kind of cardiac defect. And we've caught several of them. Hope you have a good splicer. There we go. Thank you. So touch that button and then play with other things. Okay, this is what is the maturity rating system that you probably saw when you were in Mother Baby. We used to call it the Ballard because it was a Dr. Ballard that developed it. But what you're doing is you're comparing the neuromuscular system of this baby that's in front of you and assigning points to things. And then you're comparing his physical maturity. Now, by neuromuscular, I mean how he's positioned, how tight are his elbows, what tone he has. A term baby usually has a posture of being very well flexed. They have good tone and they're very flexed. So you would give that baby, if it was flexed, 4 points because it's real tight. Preemies usually lay like a 0 or a 2. They're flat out. And I have pictures of those. There's no tone. They're not flexed yet. They haven't had that flexed position in utero, and they don't have the tone, the muscle tone to do that. So they're going to get a 0 or a 1. So you go through your baby like this, doing all of these, and then you do the physical maturity. Do they have lanugo? What do their plantars, creases look like? Do they have breast buds? So you assign point value. And then you add all of that up, and it comes up with the week's gestation. This is much closer than the wheel that the doctors use or ultrasound. Ultrasounds just do long bone growth and things like that. So this is the baby in front of you and what you see. Nursing care of a baby, we do eye prophylaxis. What are we doing that for?
GBS?
Right. Well, any kind of eye infection, really. STDs and things like that. We're using erythromycin ointment that we just place in the eye. We wait until about an hour for it to be put in for the baby and the mom to bond. We used to put it in right away, and it's like looking through the bottom of Coke bottles. So the baby couldn't really see it and see the mom. So we now wait so that they can see each other and enjoy that first hour of life. The vitamin K is given for clotting. Now, babies haven't had anything in their gut to stimulate the bacteria that they need to develop clotting factors, and that's where vitamin K comes from. After they've had some formula, some breast milk, a pacifier, a gloved finger, any kind of bacteria in their belly, that's going to help them develop the flora that they need to develop that bacteria that produces vitamin K for their clotting factors. So we give it to them to get them started. The first bath is usually put off for several hours, if not 8-10 hours into the next day. It's usually given with the parents. It's not done in the first hour of life unless they're HIV positive. At that point, it's done right away before any kind of injections or anything going on. Okay. The number one priority for a baby nurse is to keep that baby warm. A lot of chemical things happen if a baby gets cold. Their pH drops, they become acidotic, and that just cascades into other things. Respiratory distress, they don't eat, their guts get sluggish. So we want to keep them nice and toasty. To do that, we talked about the flex position that's needed. The baby on the bottom is a term baby. You can see how he's nice and flexed. Okay, good tone. And what he's doing there is he's protecting himself. There's less skin exposure with everything curled up. So he doesn't have the inside of his arms exposed. His abdomen is a little bit more protected. So there's less skin exposure. The typical preemie posture over here, he or she, I covered it up, so it's very well exposed. So that baby's going to get very cold very quickly. Now there's 4 ways to discuss thermal regulation. Convection is just like your convection ovens. It's a circulation of warm heat. So if this baby was, say you went to mom's changing the diaper and ran out of diaper wipes, and you kind of leave this almost naked baby in the crib while you run to get wipes. It's going to get cold because the air is cooler than the baby, and what happens to the heat? Goes from more to less. So the baby's heat's going to leave the body and try to heat the room. So she's going to drop her temp. Radiation is if we have a baby in the isolette. Now, in the old days of nursing in the NICU, we did not have double-walled isolettes. We had single-walled, and it got cold in there because it's like a window. It gets cold, next to the window it gets cold too. The double-walled isolettes develop a pocket of hot air around the baby. So there's like a layer of hot air all the way around the baby to help protect her. What would happen if we didn't have double-walled isolettes is the baby would radiate her temperature from her body to the wall of the isolette to try and heat it. So we keep quilts on them to help protect them from cold drafts. If you go in the NICU, you'll see quilts over the isolettes. And that also protects them from sunshine. If they're close to a window, we open the blinds, it gets a little warm, and it cuts out the light and helps muffle the sound. Radiation is if you were, say you were at the beach, you come in out of the water and you just lay yourself on a towel, and a cool breeze comes over you. Okay, what happens? You get chilled, you shiver. You're like, oh my gosh, let me wrap up, put a blanket on, get a towel. That's what happens to the baby. So you have this baby after delivery, okay, comes from 98.6, 99 degree mom, and you lay them on a warmer, and they're going to radiate their heat from their body because of all the moisture into the room. So we dry them off very quickly. We keep them dry, we keep them warm. Happens after a bath, at delivery, so we want to protect them from cold stress. Conduction is when you weigh the baby or put the baby on a cold mattress. We don't do that, but cold mattress. But our scales now are heated, so the baby cannot radiate her heat from her body to the scale because we had cold scales. It was a piece of plexiglass, and you just laid the baby on it and got to wait. Well, she was radiating her heat from her body to the scale, and that would drop her temp. So now we have heated scales. We don't have to strip the kids anymore. We can put a diaper and a pair of pajamas on the scale, zero it, and it compensates for what the baby's wearing to the scale. I wish physicians would get that in their offices so I wouldn't have to take my shoes off. General assessment. When you're looking at a baby, you want them to be flexed. We've talked about that. But you want the motion, now all the movements that the baby does to be symmetrical. You want one side to move pretty much the same as the other side. And we're going to do, when we do shoulder dystocias and ERPs, I'll show you some pictures of why. Now the color, what happens when the hands and feet are a little blue or dusky? What's that called? Called acrocyanosis. How do you explain that to a parent? From cold, immature blood circulation. They need to dilate because Mother Nature is taking care of the larger organs, and the hands and feet aren't. They're the last on the list to get their blood. You know, as they get cold, things shut down. So you warm them up, and that circulation in their hands and feet, it will improve. Now, you don't want any newborn baby to be jaundiced. That's not a very good sign. Babies are supposed to be pink. But if you have a baby who is jaundiced, you need to start thinking about like blood dyscrasias, liver problems, and call that immediately to the pediatrician's attention that the baby is getting too jaundiced or was born jaundiced, and he needs to see them. The body size has to be appropriate for the head, the trunk, the legs. You want everything to look proportionate. Okay, you don't want, you're looking at a baby, if his head looks smaller than the rest of his body, you need to look into that. If his belly looks real round compared to the rest of his body, short legs are a problem. Okay, so you want things to look like they belong to each other. Reactivity we're going to talk about, but patient identification is a high priority as far as newborn safety. It's actually patient identification in the adult world as well as in the baby world and pediatric world is a big national goal from Joint Commission and our 2019 patient safety goals is patient IDs. So everybody's trying to improve on that. Skin assessment. Milia are those tiny little white pustules on the nose, cheeks, chins, look like baby acne. That does go away. Encourage the parents, please do not squeeze them, don't put alcohol on them. And culturally, you might have to explain it to some grandparents. I walked in on a grandparent when I was over at Morton Plant. This is years ago. And she had taken the wet diaper of the baby and was rubbing it on the baby's milia. Well, if you think about it, urine has acid in it. Okay, it's got a lower pH, and it's like she was trying to dry out the skin, and that's where they came from. So you kind of say, don't do that. Let's wash the face. It's going to go away. But I'm sure when the baby got home, they went right back to where they were going to be doing it anyway. Erythema toxicum looks like bug bites. It's very elusive. It comes and goes throughout the body and the skin. They feel that it is from an irritation from blankets and t-shirts and things in the environment that the baby's not used to yet. So it looks like a little red bug bite and may have a little red circle around it, but it goes away very quickly. A lot of practitioners have gone from one floor to the next to go see this rash, and by the time they get there, it's gone and moved on to something else. So it could be on the belly, then move to the leg, the arm. It's not an all over rash, it's just going to be a couple little spots and then go away. Now, Mongolian spots are this darkened area right here on the back side of this baby, right here. This is a Mongolian spot. More prominent in Asians and African Americans. Does go away by 7, 8, 9 years of age. But the big thing to do is to document that the baby has one, so it can't be confused with a bruise later in life for an aunt that might think the mother's been popping the baby on the bottom. Okay, so you want to keep it documented just in case DCF or somebody needs to be involved. If it's, as well as with birthmarks, you document them. If they have any peculiar shapes, hearts, unicorns, anything that you can identify, then put that in your documentation, because we need to see if it's growing. You can measure it. That would be a great idea. So birthmarks grow, so you want to have that documented so that they have a baseline documentation. Common problems that you might see are petechiae. Now those are little capillary marks. It's different than the milia. It's red, but it might be the little dots. It's usually from the presenting part, what got the pressure during delivery. So you might have it on the eyes, the forehead, but you're going to have some petechiae, and it's just broken capillaries. Blisters and lesions, look for those. If a baby was a very vigorous sucker on his hands in utero, you might find a blister on the top of the hand or on a finger, whatever he could put in his mouth, and that's where you're going to find a blister, and that's just from him sucking real hard. Plethoric, babies who are plethoric. Do you guys know what plethora is? Something that is plethoric is a real ruddy red. I'm just looking for a sample. It's deep red. And it's caused by an increase in red blood cells in the baby. Baby could be dehydrated, probably maybe had cord that was drained into the baby. We do that now before we do the clamping of the cord. So he may have gotten too much. So babies who are plethoric and have a high red blood cell count, what kind of things are you going to be watching for? No.
Iron too high?
The what?
Iron level?
Well, we don't test for that. They get jaundice because red blood cells. Jaundice. And respiratory distress. Kids that have a high crit may have some respiratory distress because it just hoses things up. But we watch them very closely for jaundice. Remember, red blood cells have to break down. They die. You guys can feel it in your body now, can't you? Your red blood cells are breaking down. There's chaos going on. So you're going to have a little bit of jaundice with that broken down red blood cell. Your livers are mature and hopefully are able to take care of the red blood cells that are breaking down. This newborn baby might not have a highly functioning liver yet. Takes a couple days to kick in, so she's going to be a little bit more jaundiced a little bit more quickly. So you need to watch them very closely for that. Abnormal hair distribution, what we're looking for is if you're getting a report that the baby's a term baby, how much lanugo should a term baby have? When you're looking at a term baby, how much lanugo should it have?
Minimal.
Minimal. Yeah, should have bald spots across the shoulders and on the arms. So if you have a very furry term baby, you need to let them know about it. Okay, there might be a discrepancy in the dates. There could be things going on. So you look to see how much they have. And when we talk about the head, what we're going to do first is you're going to feel the fontanelles. And what you do is you hold the baby flat or in their crib, and you just run your hand along the top of their head. First thing you're going to feel are their fontanelles, and that's the soft spot that you always hear about. You should be able to feel all four sides of it. It should be nice and flat and very soft. What you're going to feel after that are the ridges as the sutures overlap, and it's very common in newborns. They need to be pliable. You should be able to push on them a little bit and feel movement. If you don't feel movement, if they seem to be solid, that's not good. The baby's head's going to grow and it's not going to have any place to go. So that's a medical emergency to get that baby someplace where they can open those sutures and let that brain grow. So you want the sutures to be pliable. You want them to be, they're going to be overlapping, but it happens very quickly that they go end to end. The posterior fontanelle is about the size of a pencil eraser. And it's more difficult to feel because the sutures are overlapping and it may close off, but it'll open up again. The other things you're looking for in the head are capits and cephalhematomas. Now, a capit is filled with fluid. It's from trauma, probably positional in the birth canal and took all the abuse. But it's a capit because it crosses suture lines and is mushy and boggy. You can't feel the lines very well. See, they kind of blend in real well. So this isn't as critical as the one that's filled with blood. But the way you remember it is it crosses the suture lines like a cap would. Sorry. Cephalhematomas are filled with blood. They do not cross suture lines. They are very well defined. If you would palpate this cephalhematoma, it's very firm and it's very distinct boundaries. You can almost see where they stop and start on the head. So those are the differences between the two. I'll ask you again, this baby has a lot of blood in the cephalhematoma. What are you going to watch for?
Jaundice.
Yes, jaundice. So this baby's got to break down this red blood cell, that blood, it's got to go someplace. So the first place it's not going to go is the liver, it's going to go to the skin. So the baby will be jaundiced. Okay. When you're looking at the baby's head, I want you to look at the eyes and the ears. The eyes should be clear. You don't want any drainage. The sclera should be white. You don't want it to be yellow because that's just the sign of increased jaundice. But if your sclera are blue, that is just superficial capillaries that have turned the whites of the eyes blue. That goes away as the baby matures. When you're looking at the ears, you want the epicanthal part of the eye, this inside aspect of the eye, to come straight across and be even with where the ear attaches to the head right here. So, everybody go home and check their kids and their husbands, because you want the ear to be even with the eye, okay? This baby here on your left, the second child there, has low set ears. But I'm going to venture out and say he probably has some kind of syndrome because his eyes are different. They're not normal. There's extra folds, they're more round, and his ears are very low set. This baby here in the middle has an ear tag. It's just extra skin. It goes away. If a baby grows, hopefully it will stretch out. If not, it can be removed. The cleft lip palate. When you're doing an exam on a baby, I want you to put a glove on. And I want you to really do a good exam of the mouth. I want you to go inside, and I want you to follow the gum line all the way around. You may find some natal teeth. This baby here on the bottom has 2 little teeth that are right there on the bottom. Pediatricians will just pop those out. They have no roots, and they'll just pop them out. You don't. There we go. Okay. Let's see. So what you're going to do is you're going to do your mouth exam, but I want you to do the roof of the mouth as well and get as far back as you can, just short of gagging this baby. We had a baby not too long ago that the mother complained that the baby was always spitting formula out the outer nose, no matter what position, sitting straight up, side lying, breastfeeding. The baby was always shooting formula out her nose. It was always dripping out her nose. Couldn't feel anything. Brought the baby to the NICU, and the neonatologist took a look back there with a laryngoscope and saw a little hole that was the baby's tongue. When you swallow, your tongue goes up against your palate. And as it went up, it was shooting milk through this defect up into the nasal cavity. So that's where the milk was coming from. That's a surgery that can wait. The baby was gaining weight, and as long as the baby was doing fine with it, we weren't going to mess with it. So that was something that they were hoping would fill in as the baby got older. These cleft lip and palates are usually picked up, are usually picked up on ultrasound. So the parents have a chance to do some research, learn about it. We have special feeders for these kids, and it's not quite a shock when they know it's coming. What's the shocker is that they didn't have an ultrasound. So right away we start getting the support groups, bringing people in to talk to them. We have a nurse that has a son that has a repaired cleft lip palate, and he's an adult almost now, high teens, early 20s. So he comes in and talks to them and shows them his scar, and his speech is fine and that kind of thing. So it kind of helps them see what could be. Let's see. Don't want the size of the head to be small. That's a microcephalic. Or too big. If your fontanelles are bulging and the baby's head is growing or is too big, could be hydrocephalic, a lot of fluid in the brain. And that could be a medical emergency if it's putting pressure on the brain, so that you need a neurologist for that. Now, when they're looking at the eyes, the red reflex that we get when we're taking pictures that everybody hates? You're always trying to get that red dot off their face, okay? So that's a normal response. That's light bouncing off your cornea and shooting it back at you. That's a good sign. You're healthy pictures. So what they're looking for when they do an eye exam is looking for that red reflex. Now, if they see a white one, that could be the sign of optical tumors. So when they look in there and all they're getting is a white light against the cornea, that could be a sign of tumors. If it's a black light on the cornea, it could be cataracts. So that's something they need to know, the parents need to know for follow-up. The respiratory system, you want, when they breathe, you want both sides of the chest to come up. Now, babies can be abdominal breathers, but hopefully they're not a seesaw where they do one and then the other, one then the other. So you want the chest to come up when they're breathing. You want breast sounds to be clear, equal on both sides, and you listen front, back, up, down, all over, just like you would an adult. Now, a newborn baby may sound a little bit of wetness, and that's just fluid in the lungs, and as they cry and get a little older, that will absorb. But they can also cause increased respiratory rate. So if you have a baby that's breathing in the 50s and low 60s, and they sound a little junky, that's probably just extra fluid. Common variations that you might see are accessory nipples. These are usually in the line of a mammary duct. Now there's a picture here in several different places, but you'll notice that they're all in the line of a mammary duct. Look like little moles and easily ignored or overlooked. Gynecomastia, what is that?
Before puberty, when you have breasts.
Well, even just the newborns, really. It's the newborns. How would you explain it to a dad? Dads freak out about it.
Isn't it a hormone imbalance?
It's a hormone imbalance because the baby's grown up with mom's hormones and he's developed some soft breast tissue. It does go away. Dads freak out about it because they're thinking they're having to go bra shopping for their sons. You know, that's not true. You know, kind of like it goes away, don't worry about it. But don't palpate it, leave it alone. Common problems are retractions. That could be anywhere from light intercostal retractions as the baby breathes, substernal retractions. As the baby has more and more severe respiratory distress, the retractions go up higher. If you have a baby that's sucking in at the costals up here, right here, the sternums and the clavicles, that's not a good sign. They're working very, very hard. Tachypnea we've talked about, and we've talked about the rales, the noisiness that you might hear the first couple days. The cardiovascular system, you want the babies to be pink. Normal color is pink for a baby. They should have the normal rate and rhythm. You don't want any long pauses between the beats. So you have to listen for a good minute to be able to recognize when there might be a pause. You want brachial pulses and femoral pulses to be pretty equal and succinct. You want, when you hear the beat up here, feel the beat up here, you want to feel it down there. Murmurs are very common in newborns. They're the patent ductus arteriosus is the flow murmur. That's the little vessel that the baby needs in utero to bypass blood going to the lungs. So, and it may take a day or two to close off. So as the baby's born, the change in pressures in the body will close that vessel off and everything will be fine. The tricky part is if you get a sick baby or have a premature baby, those vessels open up. It's like, hi, I'm here again. But what's happening is that it's diverting blood away from the lungs to the body. So the baby's not able to oxygenate themselves. So you have to tie them off surgically. There's medications we can try. But as we see the babies get sicker and we do an echo, you could see the blood being diverted away from the lungs and it's not getting any oxygen. So baby's on a vent and having increased needs for oxygen support. We talked about acrocyanosis. Persistent murmurs could be a PDA that goes on for several days or weeks until their pediatrician's visit. It's not causing the baby any problems. They'll just watch it. But you could have septal defects. You could have ASDs, VSDs. And if the baby's not having any problems or showing any symptoms of having any problems, they just watch it. And just follow it up with echoes serially. Cyanosis, if you're feeding a baby and they may turn a little blue around the mouth, that's not good. So any kind of cyanotic episode with crying, with any kind of exertion, bottle feeding, crying, just sleeping, they slow down their breathing and don't breathe deep enough, and it causes cyanosis. That's not a good sign. We want to know about that. Tachycardia, that's not appropriate for this baby. So if you have a nice chunky little term baby and he's beating 200 times a minute sound asleep, that's not good. Okay, we want to know about those. And the vice versa, bradycardia. Anybody whose heart rate is lower than it should be, we need to see. Your abdominal assessment, we want the belly to be nice and round, but not so full that it is difficult for the baby to breathe. So we want it to be nice and round. We want it to be soft. You want to be able to palpate gently all 4 quadrants. You want to hear bowel sounds in all 4 quadrants. So it's very important to take your time and listen and hear the gurgling in all 4 areas. You want the umbilical cord to have 2 arteries and 1 vein. That's an AVA. But it is not uncommon to have 1 artery and 1 vein, and the baby does just fine. Some variations that you might see are a little hernia at the umbilical stump, and all that is a weakness in the muscle wall there at the stump as the belly button, as the umbilical cord comes up through the belly. The muscle underneath it may poke through a little bit. And if it can be reduced and isn't causing any problem and they don't think it's going to strangulate, then they'll just follow it. But if it's going to be a problem and they have to keep reducing it and the baby cries and it pops up, they may take the baby to surgery, push it through, and take a few stitches to close it off. If you have a baby who is distended and has no bowel sounds, that could be a medical emergency. You want them to have stool within 24 hours. If they don't, they could have a meconium plug and not be able to. Here you are encouraging them to eat and it's no place to go. So we need to know, because we don't have any magic wands, we can't see everything, so we go by symptoms. If you have discharge or any kind of leakage from the cord, it could have ripped a little bit at delivery. So at the base of it, or where it took a lot of the tension, there could be some leakage or ripping that would cause it to leak. So you need to watch that. And abdominal masses, when you do an abdominal assessment, put your baby on their back and lift their legs up a little bit so the tension isn't pulling their belly down. So lift their legs up and see if you can palpate very gently all 4 quadrants. If you feel something hard that doesn't feel like it needs to be there or wasn't there the day before, please let somebody know. This is a picture of umbilical cord harvesting. We do that at Countryside at delivery. They'll harvest stem cell blood for the parents and package it and send it off. We don't do any of the arrangements for it. The families have to do that. We just collect the blood at delivery. Okay, the genital and anal assessment. Like I said, you want the baby to pee and poop within 24 hours. Very important. The anus has to be patent, and we used to do rectal temps on everybody to make sure, but if you think about it, it could be occluded farther up, and we wouldn't know about it. So it wasn't doing us any good. And it's traumatic, and some kids got perforated at the rectum, that kind of thing. So we don't do it anymore unless you have a doctor's order. You want both testicles to be down into the scrotal sac, so you should be able to feel them. If not, check and see if you can feel them along the inguinal canal, and that is about in this area here. So if you don't feel them here, check up in here. You might be able to palpate a little lump, and that would be the testicle trying to come down. And that would just take time. You want the meatus to be at the tip of the penis, but check the penis for any kind of openings. The meatus may be at the base of the scrotum or base of the penis, so that he's not peeing outside the tip, he's peeing at the bottom. Those are hypospadiuses, and physicians need to know about those things. Where's the pee coming from? This is a picture of a hypospadias. I have seen hypo all the way at the base of the penis, and I've also seen epispadiuses, where the meatus was at the top. Hydroceles, that's from trauma. That's the top picture. It's a hydrocele. It's just fluid from trauma, from delivery. That does go away. A hymen tag and vaginal discharge. The discharge is from hormones, similar to gynecomastia in baby boys. This is pink streaked vaginal discharge in little girls, and that does go away. A hymen tag, if you had your baby on their bed, face up, and you held their legs up, you might see a little tag at about 6 o'clock in the vagina that just kind of falls out. That, as the baby grows, it stretches up and goes back up into it. So it's just part of its tissue that just goes up. And we talked about those. Circumcisions. Anybody see one? Oh, go ahead.
Would they do surgery right away if they have the hypos, whatever, sphincter?
It depends on the urologist. Those kids do not get circed, and that's what I was coming to. They don't get circed because they may use the foreskin to help with the repair.
But they wouldn't do that. You can't get that done right away.
No.
You have to wait to have that.
Yeah, they may have to wait if it's not causing the baby any problems. They may wait until he's a little older, so you have more to work with.
Gotcha.
But they want to do it before it becomes a traumatic event. Okay. As the baby boys get bigger, they're more protective. Circumcisions. Everybody see one? Anybody see one? Yeah? What'd you think?
The baby was, the baby was okay. As long
How did
as
they
the
do it?
pacifier wasn't, I'm sorry?
How did they do it?
They strapped his arms and legs down, and they put like some drops in his mouth. I guess like sugar.
Sweeties. Mhm.
Yeah, and then
Sweeties.
they kept the binky in his mouth. And I mean, that doctor didn't numb it. I asked her why, and she said because even when they do numb it, they do it right away, so sometimes it doesn't even help anyways. But the baby really wasn't crying that bad if the binky was in his mouth.
Yeah, Sweeties is great.
And yeah, they released it from the head, and then they put this metal thing on there,
Mhm.
and then pulled through and cut it off.
Cut it off.
That's the end of it.
I know, it's just the way it is. And it sounds like the Sweeties we have had some resistance with, but it sounds like more and more doctors are going with it because the babies are laying still, they're calm.
Yeah.
What the Sweeties is 25% glucose. It's like sugar water on steroids, high power sugar water. And it changes the chemicals in the head. It develops dopamine, that feel good chemical in the head that everybody needs. It's like sleeping for 20 hours and waking up refreshed and feeling wonderful. Okay? Like sleep deprived students don't have, right? Okay. So your first day off, you sleep for 20 hours and you wake up feeling absolutely wonderful. And that's what sugar water does for these kids. It makes them feel good. So they really don't care what you're doing to them. So what they do is hopefully they have swaddled the baby. Did they tie the arms down or
Yeah, they
swaddle?
the arms.
Swaddled.
They tied the legs.
That's good. Okay. Hopefully they've swaddled the baby and kept the baby close to themselves and warm. Tied the legs down. Start with a pacifier and the Sweeties a few minutes before the procedure. Some doctors will still do a block at the base of the penis, and that's their call. This physician, girl or boy?
It was a woman.
A what?
It was a woman.
A woman. There's some physicians that they don't want to wait, and that's the thing with the box at the base of the penis. You have to wait a few minutes for it to take effect. So some physicians that I've helped with circs, they'll do the block and then they'll hold the baby, that kind of thing. They'll pick the baby up and start holding and rocking, and then they'll put them down to do the circ. So it's their call. But there's a lot of kids that if you give them Sweeties early enough and bundle them and give them pacifier and somebody's there to calm them, then they usually do pretty good. But the circ is, you probably saw the Gumco on the far side. And what they do is they take a hemostat and they pinch the foreskin to make it very paper thin. And that's killing the nerve endings and deadening them, and hopefully will control some of the bleeding. So they pinch it to crimp it, and then they take scissors and cut it. And then they slip this hood over the top part of the penis so that it's over there, and then they pull the foreskin up. And then they tie it sometimes, or they take this machine called the Gumco, They'll slip this over it, slip this head down, and they'll put this on it. And as they're twisting this, this is becoming very, very tight. So it's gonna pinch all the blood vessels and the nerves, and hopefully they're letting that sit there. Did they let that sit there for a second?
Yeah.
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 And he didn't cry at all when she was
No.
cutting it.
So, kids are resilient, aren't they? So then what they do is they'll pinch that, let it sit there for a minute to help control the pain and the bleeding, and then just take a scalpel and take the foreskin off. Care after this, you have to watch for bleeding. They have to pee. You don't want it to become so swollen that they can't pee. But bleeding and discomfort is part of the package. What happens is they will cry when they pee in their diaper because it's like a big open wound, so they might become a little bit more fussier. So you need to let the mother know that this is going to hurt for a day or two. You can put 4x4s with some Vaseline over it to tent it so the Vaseline helps protect it. And then what we tell them to do is take Vaseline and put it on the inside of their diaper so the diaper doesn't stick to it. That hurts being pulled off. So they do that for a day or two until it looks less red. It's going to go from red to more normal color. And they'll do fine. I was going to say something. Oh, one of my favorite stories with circumcisions is, now, I've been out of nursing school for probably longer than most of you have been here. So a long time ago, circumcisions were not so vogue. We just didn't do them. And my very, very first patient in nursing school, and I had gone through yes, I know how to make a bed, because it was a lot different back then. I had to spend 6 weeks making beds. So I knew how to make a bed and all that, and I got my first patient. And it was an 18, 19-year-old big strapping football player from Brandon High that had to have a circumcision for repeated urinary tract infections. I was so upset he wouldn't let me see it. You know how a good nurse, you have to see the site, right? You have to check for bleeding, you have to check for swelling, discomfort. Bring me ice, bring me morphine. That's all he wanted me to do. So all day long, I'm bringing him ice and, you're all right, I'm fine. That kind of thing. He didn't want me to look at it, and it's fine because I wasn't much older than him anyway. So, so it's kind of like, as an older gentleman, it was more difficult for him to have it done. I live in Heritage Springs, an over 55 community up in Pasco County, and there are a lot of seniors up there having to have circumcisions because of repeated urinary tract infections, and it's very hard when you're 70 and 80. It's a major surgery almost. The musculoskeletal assessment, we've talked about normal tone and flexion. You want them to be able to move around. You want the symmetrical movement we've talked about. Common variations are the hips. Now, I don't do a Marlowe's or an Ortolani's, but a Barlow's maneuver is when you have the baby on their back and you can actually seat the head of the femur into the hip socket, so it's seated. An Ortolani's is if you pull it out in a circle, and you're feeling for any clicks or ridges or hang-ups, so you want a nice smooth motion. I hold the baby up and I look for folds. Now, if you look at this baby here, if you hold her up, one leg is shorter than the other, which is a dead giveaway. And then there's a fold here. So I'm going to guess that this hip isn't seated right, causing this fold and causing this leg to be shorter. Here's uneven abduction. You have the baby on their back, and one leg goes all the way out and over, nice and easy, almost frog-like. And the other one gets hung up and stuck. That femur isn't able to move outside that socket, so there's something hanging it up. The knees are uneven, so when you have them on the back, see if their knees are even. One knee is shorter, lower than the other. Chances are there's a hip that's sitting right and one's not. So find one that you feel very comfortable with and practice it. Some of the things that you need to look for are fractured clavicles. We'll talk about them a little bit more in the next presentation, but what you're doing is with shoulder dystocias, it's not uncommon at all for the baby to have a broken clavicle. Now, the clavicle for a newborn is made to be broken. Mother Nature built that in as an escape route, if you want to think about it. So it's very, very easily broken. It's not like ours. But what you do is you palpate all the way back here, and you want to go all the way down like this on the baby. You're feeling for any kind of crepitus or air bubbles underneath that would have formed, any ridges, because they sit like this, so you're going to be able to feel this ridge here. And we essentially just leave them alone. Now, the club foot is frequently confused with a foot that's been in position like this for a long time. So as the baby's in utero, if there's no place for the foot to go, they think it's going to, go like this. But a club foot is the boniness of it. It's not soft tissue, so it cannot be repositioned and pulled out. Syndactyly and polydactyly are fused fingers and toes. If it's just flesh, soft tissue, later on they can take it and cut it open and separate them, and then wrap each one with Vaseline gauze to keep them from sticking so that they will develop, they'll heal separated. If it's a polydactyly, if it's a simple one like a extra finger or toe on the side, they'll just take some sutures, if it's just flesh, soft tissue, and tie it off so the circulation doesn't get there and support it. And it'll just die off and, go away. Anything that's bony has to be repaired surgically, because then they have to decide, which one to take off. There was they took out one of his middle fingers that were kind of not developed very well, and turned the first thumb into his first finger, and then kept this as his thumb. So it was a little bit of space here, but it looked very natural. But they had to let him grow to get that sense. It was very interesting. These harnesses are used for hip problems. This is reduction cast. I worked at Shriners for several years, and we did a lot of hip surgeries on toddlers. And these are called spica casts, and they go from below the toes to above in the chest, and they just leave areas open. You want to leave the belly open so they can breathe and eat, and leave the diaper area open. The diapers are just kind of placed in there like this. These guys stink after a while because they get peed on, they get hot and sweaty, and the kids are in them for like 6 weeks. So they're not nice. We used to have bottles of peppermint oil that we'd rub on the cast so we could tolerate them. This baby here probably had a club foot because her foot's involved too. Now, depending on the severity of the defect, they could go into a Pavlik harness. And this is just a harness, looks a little bit more comfortable. It pulls the legs up into that flex position around the shoulder, so if she tries to fight it, it just pulls on her shoulders and she can't go anywhere. These are a little bit more comfortable. They can be washed. The baby can come out of them for bathing. Their first order is usually 23 hours a day. Leave it on for 23 hours a day. So that gives them an hour for a bath, for tummy time, to play, that kind of thing. The neurologic system, you want normal reflexes. Rooting, sucking, Babinski's, planters, that kind of thing. You want everything to be normal. And the thing with reflexes is you want them to go away when they should. So you don't want a year-old baby still rooting. They should know what a cup is and a bottle and take it. So there should be no root. That goes away. Erb's palsy is what this baby has. You'll notice that his arm is kind of dangling. What probably happened, and we're going to talk about that a little bit more, is he may have been a shoulder, and they pulled on the head, and what they did that is stretched all this part out, and it stretched out that nerve. So he has really no control of that arm. That does go away. That just heals. If it takes longer than they expect, then what they'll do is they'll order some PT and teach the mom how to do some passive range of motion so that the baby can be supported with a cast and heal by himself, but that does go away for the most part. Spina bifida, when you do an exam on a baby, I want you to turn that baby upside down and hold them like this so that they're like that. You know, feet down here, head down here. And I want you to palpate from the top of the head way up here all the way down the spine so that you would be able to feel every vertebrae and feel for any bogginess or separation. And that's how you pick up spina bifidas. You know, they could be under the skin. A blatant one is going to be a defect you'd notice at delivery. It's going to be a big hole and a big wound in the back. Anencephalics are kids that are born without most of their brain. They're born with the brain stem and the lower part of their brain. We keep the kids warm. We feed them by tube. Some of these kids die within a couple days. Some of them live longer and just go home and the parents take care of them. They want them to be included in their home life and be a part of their lives. If you notice abnormal or absent reflexes, that's not a good sign. We need to know about that. Any kind of seizure activity. Now, seizures in newborns are not like tonic-clonics that you would get in an adult. They could be as subtle. They're very subtle signs. So they could be lip smacking or eye blinking or staring. So, you know, you think that, oh my gosh, she's being so good. Look at her staring at the butterfly on the window. That could be a seizure. You know, if you go like this and nothing happens, she could be having a seizure. So she needs to respond to you when you do something. Could be tiny little tremors of her hands, that kind of thing. All right, shift assessment. When you are taking report, and I'm just going to go over these quickly because I know you've done these. Shift assessment is make sure you discuss vital signs and the baby's weight. Are they gaining weight, losing weight? What are they eating? Are they peeing and pooping? Remember, you got 24 hours. If it's 25 and he still hasn't pooped, somebody needs to do something about it. So we're hoping that one of the two nurses have talked to each other and discovered that. Bonding in infant care and the hips. What are the hips looking like? So making sure that the mother is doing everything that is normal for day 1, day 2, day 3. Are they breast pumping? Are they breastfeeding? How's the mom doing? How's the dad doing? Nobody ever asks about the dad. How's the dad doing? What are the siblings like? Okay, this is periods of reactivity. When you're working with a family, the first hour is usually like this. The baby's engaged, the mother's engaged, everybody's looking at each other. Notice we haven't put the cream in the ointments in the baby's eyes yet. So they go from here. And then what happens is they get a little tired and they go to this quiet alert. They're kind of like in this zone. So it's a quiet alert. Now, the big thing with reactivities is to kind of know how to get them to go from one stage to another and when it's appropriate to do that. If you're working with a mother with breastfeeding, are you going to do it in any of the sleep states? Deep sleep, light sleep, you know, in a baby in a deep sleep, you're going to be smashing their face into the breast and he's not going to care. He's in a deep sleep and they can block out anything. So if you want to work with the mom on breastfeeding, I would consider maybe this active alert because that baby can probably be consoled, calmed down, and put to breast. He might be lightweight because he's hungry. Light sleep, those are the perfect. They're just waking up, they're interested, that kind of thing. They can be aroused, change their diaper, take their vital signs, and then put the baby to breast. This baby up here that's in the bathtub crying, that's a state that they will not do anything. That kid has to be calmed down, has to be comforted, swaddled, rocked, swayed, and hopefully will calm down with the mother's voice and being offered the breast. But at that extreme of a state, you have to bring them back. You just can't put them to the breast. So by teaching the moms these states, they're going to be much more successful in the interactions of their babies. And they can go from one state to the other within seconds, or skip some. Infant nutrition, we all know that breast is best. Breast and formula for 12 months minimum. We're trying very hard not to offer solids right away. They don't need solids. Everything they're getting is from the mother's milk. So they're growing just fine. Offering solids, there's evidence out there that supports food allergies. So, you don't want to offer them things too early. Babies need about 95 to 100 kilocalories per kilo per day. And in the NICU, we calculate that. We know how much our kids weigh, and we calculate fluid in and take into consideration their IV fluids, their TPN, the breast milk, that kind of thing. And breast milk and formula is about 20 kilocalories per ounce, but manufacturers can make 22, 24, 26. For breast milk, we can add human milk fortifier, make it 22, 24. We can add protein, add polykos, add MCT oil, whatever. The dietitians work very hard in developing things that these kids need. Okay, I'm going to give you a